So the second area was to diagnose either more reliably, more cheaply, or more quickly to make the correct diagnosis of sepsis. And I think one that always comes to mind by me is diabetic ketoacidosis. So by definition, when patients come in with DKA, they're going to have at least two SARS criteria. They're all going to be breathing fast, and they're all going to have relatively elevated heart rates. A lot of times, because you're breathing fast, there was a study a number of years back that documented the temperature if taken orally in a patient who's tachypnic will be inappropriately low. So they could have fever and you may not know it early on. We're always looking for the cause of DKA, so I think a biomarker such as procalcitonin would be a good quick screen to define whether or not these patients need to be looked at for sepsis. I think the other areas of shock patients that come in, they're hypotensive. And I tell the residents, you've got about 10 to 15 minutes to try to decide what type of shock these patients are in. Is this cardiogenic shock, hypovolemic shock, et cetera? So I encourage them to utilize a number of biomarkers. So C-reactive protein, procalcitonin, you have to look at the EKG quickly, cardiac enzymes, cortisol levels, et cetera. The point being, if sepsis is the diagnosis, then the timing of our antibiotics and getting early goal-directed therapy started early is critical. And then finally, we have a number of patients that are, quote, found down. Sometimes we joke around and say this is like our number one diagnosis in the medical ICU. Patients found down at home, nobody knows what's wrong with them, come in, get intubated in the ER, then they get sedated and chemically paralyzed, and by the time we get called to go see them, we don't have a clue what's wrong with them. We can't take a history anymore. There's no family. Very difficult to get a good physical exam, et cetera. So this is an article by Mueller looking at calcitonin precursors and making the diagnosis of sepsis in a medical intensive care unit. And this is an article from 2000. So the point was that, again, similar to our own intensive care unit, 99% of the patients admitted to a medical ICU have two or more SIRS criteria to begin with. And again, since infection is one of our most common medical ICU diagnoses, we're always want to make sure we don't miss that one. So they compared the usefulness of procalcitonin, C-reactive protein, interleukin-6, and lactate for the diagnosis of sepsis. So they looked at 101 patients that stayed for at least 24 hours. Now, ultimately, in their trial, 58% of the patients were found to be septic, so you can get an idea of sort of the prevalence of sepsis in this subset of patients. And these were the numbers. So the sensitivity for procalcitonin was 89%, specificity 94%, and those are the positive and negative predictive values, and compared to the other ones. And when you look at this graphically, this is the receiver operating characteristic curve that you'll see a lot of these plotted out in literature today. But the idea is that if you had a straight diagonal line, then that test is completely unhelpful as far as helping you make that diagnosis. On the other hand, a perfect curve would go straight up the sensitivity line and straight across the specificity line. And so what they'll talk about is an area under the curve. So the percentage of the area under the curve, the better the test is. Now, I just want to go back briefly to the numbers here, sensitivity and specificity, because one of the other things that you'll hear about is a term called the positive likelihood ratio. And this is the sensitivity divided by 1 minus the specificity. And a lot of people talk about with tests that we do that we're looking for a positive likelihood ratio of greater than 10. And in this trial, the positive likelihood ratio was almost 15. The point is, if your pretest probabilities, we already said that this subset of patients, 58% of them were septic, with a positive likelihood ratio of 15, that brings your post-test analysis up to 95%. And again, that sort of correlates with the area under the curve of the procalcitonin curve. This is the second article that we referred to earlier, Harbarth, and he looked at patients with SIRS and possible sepsis. So these were 78 SIRS patients, possible infection, and they looked at the diagnostic value of procalcitonin, interleukin-6, interleukin-8 on admission for patients. And the bottom line was that procalcitonin was the best. They used a cutoff. Remember, we talked about the numbers before, but the cutoff for them was 1.1 nanograms per milliliter, and that had a sensitivity of 97%, a specificity of 78%, and the area under the curve of 0.92. Now, the interesting thing on this, as I referred to earlier, was that the clinical criteria, the physicians at the bedside trying to decide is this patient septic or not septic, they were only correct 77% of the time. However, if you added procalcitonin to this, you can improve that to 94%, similar to the last study I talked about. So this is the ROC curve for these three. So procalcitonin had the best curve compared to the other two. And then if you look at the area under the curve for the clinical diagnosis, it was only 77%. However, when you add to that the procalcitonin value, you can raise that up to 94%. And again, the point was interleukin-6, interleukin-8 did not help in making this clinical diagnosis. This is the other article I referred to earlier, talking about our ability to clinically make the diagnosis of infection. But this came out in 2010. And these were all patients admitted through the emergency room with a fever, and fever is defined as greater than or equal to 38 degrees. And at the end of the trial, a blinded panel defined whether or not the patients had infection or not. So all these patients, if you look at the percentage, approximately 84% of the patients had infection. Now, again, the physician judgment was correct only 73% of the time. Now, ultimately, when you look at the article, they came out with a formula that utilized procalcitonin level, C-reactive protein level, and the presence of chills or not, that gave them the best data to define whether or not the patient had sepsis. But I think the really interesting thing, if you just look at the positive predictive value of procalcitonin greater than 0.7, just looking at that alone was 92%. So their conclusions for this is that procalcitonin was helpful. C-reactive protein was a little bit more sensitive. In other words, it had fewer false negatives, but procalcitonin was more specific. It had fewer false positives. So how important is it that we make a diagnosis of sepsis quickly? Well, procalcitonin is a lab test. It takes about 20 minutes to run. And I think when you look at that and get turnaround time, get the blood to the lab, get the results back, I think it's something that can give useful information within an hour. And is that important or not? Well, according to the data, it really is. This most recent article by Getsky from 2010 looked at retrospective analysis of emergency room patients that all met criteria for early goal-directed therapy. So if you remember the early goal-directed therapy criteria, it's all patients who are either hypotensive after their fluid bolus or they have lactate levels greater than 4 regardless of their blood pressure. Now, these are all patients that are thought to have infection. So looked at 261 patients. About half of them qualify at triage when they first enter the emergency room, and the other half meet early goal-directed therapy criteria later on during their stay. Now, cryptic shock, that's basically meeting early goal-directed therapy criteria by lactate levels, not by blood pressure, is 48%. And it's cryptic because the idea is that these patients don't necessarily look bad. And again, you're identifying these by lactate levels. Now, I don't know about some of the institutions. We can get our lactates back on a blood gas right now. But up until just a year or two ago, we actually had to get our lactates back from the major lab, and that often took longer than an hour. Now, I think one of the sad things that was brought out in this study was almost 15% of the patients got inappropriate antibiotics, and I think we can do a better job there. But the point of this study was if you can get antibiotics started early, okay, within 1 hour of meeting early goal-directed therapy criteria, you can have a major impact on overall clinical outcome. So the mortalities went from 33% down to 19.5%, 38% to 25% if you could get started at your antibiotics within an hour. Now that's a 14% absolute reduction in mortality, which is huge. That's equal to a number needed to treat of only 7. So for every 7 patients that we treat with antibiotics within the first hour, we can save 1 additional life by doing that. And that's huge when you compare that to other things that we do in medicine. For instance, if you look at patients coming in with ST elevation acute MI and whether or not they go to the cath lab or not, the number needed to treat there is probably 30 or 40. So there's a lot of potential here to save patients with sepsis if we do a good job, if we make a diagnosis early. So this was the third area that Dr. Marshall talked about, risk stratification. I know many of you utilize Xigris in certain scenarios, and we always discuss, well, which patients are good candidates for Xigris and which ones are not. It's a drug that costs $7,000 for a course of therapy, so we shouldn't just use it willy-nilly. And I think the better the procalcitonin data looks, I think more likely we can use procalcitonin or other biomarkers in our protocol to help define who's going to get this expensive therapy or not. We were involved in the ACCESS trial. It's another one of the new sepsis drugs. This trial is not out in print yet. But I know when we talked with them and going through this, they were drawing their own procalcitonin levels for this trial in the hopes that at the end of all this, they would be able to define a level that would be more likely to benefit from their drug versus not. Lactate as a biomarker already triggers early goal-directed therapy, as I talked about, and maybe an elevated procalcitonin level should also. Higher levels may change admission decisions or intensify the monitoring decisions. So if you have a patient who looks pretty good, but their procalcitonin is very elevated, you may monitor that patient more closely in a telemetry ward as opposed to a regular ward, or it may increase the frequency of your vital sign checks, etc. The other thing is that persistently higher levels may prompt some discussions about limitations in care. And I know we have 4 different physicians and we all try to predict who's going to die and who's not. It's very, very difficult. But to have some more objective data that can tell you, boy, this patient's not doing very well, and it's not just my opinion, I have objective data to back that up, kind of gives us that confidence that we're not quitting too early.